Since you've been a pharmacist, what would you say the number one thing that has surprised you the most?
Just the daily grind that we don't really have time to help the customer, help the patient. There's the push to do everything else versus who's there in front of you, which is the customer.
Right.
Very few of the patients know that we are that aware of what, well, my doctor wrote it for me. He must want me to take it. It must be safe. No, not necessarily, depending on what else you're taking or your age, or your medical conditions. Your doctor writes the drug. Let's say Jardiance versus Farxiga. They're two diabetic medicines.
Okay.
They're sister drugs. They're in the same family, they do basically the same drug.
Okay.
The insurance, PBM, may prefer one or the other because they get money back from the manufacturer.
Hi everyone, welcome back to My Patient Advocate. I'm Rachel Nash, and today I'm joined by someone who spent over 13 years helping people navigate the world of pharmacy and patient care, pharmacist Christopher Williams. Pharmacists are one of the most accessible, perhaps the most misunderstood professionals in healthcare today. Today we are diving into what really happens behind the counter, how patients can become empowered, and what changes are needed in the system to better support everyone. Chris, I want to thank you for being here. If you could start and tell me a little bit about yourself, your story, and can you tell me a little bit about what led you into pharmacy?
All right, yes ma'am, Rachel, glad to be here. I went originally to college to become a teacher. So I taught, went to NC State, graduated in 1996 through North Carolina Teaching Fellows, which is a great program. I think it's still going, so hopefully so, because the world does need teachers.
Yes, it does.
And it was, purpose of it was to bring some of the best and brightest into the teaching field. Those that were kind of may have been pushed into something else in college, but they kind of attracted them, or what's the word?
Had a kind of a calling? A calling to be teachers?
Yeah, so we went out and you had to apply for it, and it was more of a, recruited, that's what they recruited some of the best and brightest to become teachers. My sister is also one, so she went through the same program. She's in Alabama teaching still now. Okay. So they recruited us. We went through the program. They paid most of the schooling back then. So graduated from NC State with the chemistry and science education background. Taught school for 11 years. So that's kind of where the background.
Didn't know that.
Yeah. So taught school for 11 years, teaching high school science. Saw the change in education where they were trying to route kids into certain, like choose kids what they want to do early on, which sometimes you got to grow up and decide what you want to do through experience. Right. So they were cutting out some of the experiences of vocational ed or college. Like they still had the early college things, but they were cutting out where the kids could go and try other things other than just becoming, like getting ready for college. Okay. So this was in Eastern North Carolina, so it's close to Campbell University is where I went to pharmacy school. And so I did a year of catching up some things to get into Campbell, and then got a doctorate in pharmacy and along with a master's in clinical research. Wow. Through Campbell University. Okay. That was graduated 2012. So I got a little bit later start in pharmacy, but it was worth the effort of wanting to do a little bit more medical related, but still had the chemistry background to help understand the world of pharmacy and pharmaceuticals.
I think second careers are sometimes the best careers.
Yeah, because I've always and part of as going into the later stages of this pharmacy career, helping people, recognizing other people, like the technicians at work, helping them understand you probably don't want to be a technician all your life. Right. It's a grind every day, but helping them what do you want to be when you grow up? This is a start. This is maybe second career for some people, like you said, or maybe a start into doing something different. Because I know there's one technician that was worked with recently. She's going back, and I think she's going to become a PA, which is
that's wonderful.
That's wonderful for her, yeah.
So you have those conversations with the technicians and maybe the younger technicians where it's their first career.
First job out of high school or first job, like they go into community college, get their technician's license just as a start. As a jumping board, what they want to do later.
Okay. All right.
Yeah.
So are the technicians and the pharmacists, do they all come together? They work together? Can you kind of explain what that looks like behind the counter?
Well, and that's what I said I was going to say today is like the teaching background helped a lot because it is a lot about education, and teamwork.
Okay.
Technician, it's a team because anytime in the pharmacy, most places, retail pharmacy, even the community pharmacies now, there's a lot going on.
Okay.
And negotiating today, what is the priority? The priority should always be the patients. And sometimes that gets left behind, unfortunately, in the grind of corporate retail pharmacy today. So again, trying to manage today is the pharmacist's role. It's kind of like the teacher at points you're teaching them new policies, new procedures, new ways to do things, and then managing. Sometimes, a lot of times they call it the quarterback. You're quarterbacking the team, keeping everything in alignment.
Okay. Can you explain to the viewers the difference between, so you have your corporate pharmacies, you have your pharmacies in the your pharmacy in the hospital. Can you explain that or elaborate on that a little bit, what that looks like?
Right, different types of pharmacies. You have your major retail pharmacies. You have your Walgreens, your CVS's, Rite Aids, Sam's Club, Walmart, all those kind of corporate level where you go and most people probably go get their medicines.
Okay.
You have the community pharmacies, which has always been what people have grown up with. Your corner pharmacy, own one owner or maybe just own a couple pharmacies. And you always thought, okay, they're a little bit more personable.
Okay.
Look, they usually hire more staff because they're catering to the community as more of a caregiving. A lot of times we talk about, and another type of pharmacy being mail order pharmacy.
Okay.
And you always think of the community pharmacies most likely to deliver. They will go out and deliver to their patients a lot of times still.
The communities do? The community
pharmacies, owner-operated pharmacies tend to more, and you find them more probably in the rural area.
Okay.
They probably get drowned out here in Charlotte. They probably would get drowned out other than the suburbs. Hard for them to survive.
So are they struggling for the most part, do you think, the community pharmacies, because are they not able to compete with the corporate pharmacies
Mostly
overall?
not. They have to find their niche, I would say. So,
okay.
Like I said, community pharmacies would have to find delivery, find what caters to their population. A lot of them would be the ones that do compounding. Sometimes you have to compound, they're talking about compounding the Zepbounds now, or Manjaros and type weight loss and diabetes drugs.
Okay.
Possibly they can compound those because commercially we can't sell the generics yet.
Okay.
They may deliver, like we said. They may still offer MTM, medication therapy management.
Okay.
Where they sit down with the patients and discuss what they're taking. Retail world, we don't have that time.
That time to do that. Is that something that you miss? Is that something you wish you had time to do?
I did a couple, probably a year in community pharmacy in between a couple corporate jobs.
Okay.
And that is to go sit down with the patient and discuss what they're taking, discuss what to expect from them, and what to discuss with their doctors a lot of times. Like if they're having trouble, like you said, I always think you're going to spend more time in the pharmacy than you do at the doctors. Now you may have to wait at the doctors, but the actual time you spend with the doctors and nurses is much less than you have probably ever spent talking to someone in the pharmacy.
Yeah, especially today.
Today.
Today. So here's my question that I've never really understood. And when you use multiple pharmacies and you use multiple doctors, what is the potential harm of that? And is there a system that pharmacies have where you can see in case there's repetitive medications, and do we have anything in place to keep somebody with dementia going and not knowing what medications they're taking, or if somebody sees their doctor and they get 5 minutes and they're lost because they have a passive personality? Not
really, because a lot of times the doctors will call us and ask them what they're taking. They will get a couple, 2 or 3 times a day. Nurses will call, hey, we need a med list for a patient, or the hospitals will call, we have this patient that says they go to your pharmacy, what are they taking? So the biggest, I say most people go to one primary doctor, but a lot of the confusion occurs when they go to the hospital. They're in hospital care, or they change doctors, or they may have to change. Another thing I saw today we can bring up too was like the changes when they change their insurances and they change formularies and therefore they're changing their medicines per se, possibly. So I say the biggest trouble I have with people is they need to pay attention if they go to the hospital and the hospital doctor changes their medicines, is to discuss that with their doctor, because that's a lot of where the hiccups occur. Now, some people may see a psychiatry doctor and then see a primary doctor, and there may be some crossover there, like what are we taking here that can affect what I'm taking from my primary doctor.
Right.
Or pain management and primary doctor. Sometimes they'll overlap, but that's more of we kind of watch out for that to make sure they're not overlapping things that will harm them.
How does somebody manage it that has nobody to help them? Do you think a patient advocate would be helpful if they're not feeling well and they're in the hospital or they're just very confused? I mean, how do they get around this? Do you ever see that where they're just not?
There are several people I see that are confused about what they're taking or why they're taking, or they're caring for someone and they really probably need someone, a nurse or an advocate that can help them see and understand what they're taking.
Okay.
Because, like I said, community pharmacy could probably have more time to help them.
Okay.
And community pharmacy is getting kind of pushed out of the pharmacy game because most of the benefits, the money that's made in pharmacy comes through the insurances and the PBMs, pharmacy management.
Thank you for saying.
Business managements.
Okay.
Managers, they control where the money goes.
Okay.
Paying for the drugs, obtaining the drugs, how much the drugs cost, how much money is going back to the pharmacies.
Okay. So when someone purchases a medication or there's been changes, and what happens if there's are there ever red flags that come up, and what happens in a pharmacy if there's a red flag?
Like I said, most pharmacies, even community pharmacies, have like a system, and for what we have on record, it will tell us what they're taking, but that doesn't tell us what they're getting at a different pharmacy.
Okay.
Now their insurances will sometimes flag us, depending on the system. Sometimes the insurances will give us some feedback as to they may be taking this other medication and we can look into it. Okay. Rarely that. I say that's not a foolproof system as far as insurances would be a link between the pharmacies to let us know what people may be taking different than what we're seeing on our end, what we have. So there's some catches for that, but mostly for control medicine. So like our blood pressure medicines that we may be overlapping, because people do take 2 or 3 blood pressure medicines at some point eventually, or diabetes medicines, because unfortunately the United States is getting a little bit more diabetic prone, unfortunately.
Okay, all right.
So we got a lot of diabetes medicines as we add on that can harm each other, or they change. And the changes may become from the doctor, they may become from the insurance.
Okay.
As far as what the insurances want to pay for. Community pharmacies, I say, would be the best option to get for a person that needed understanding, to find a good community pharmacy where the pharmacy can deliver the drugs the insurance will pay for.
Okay.
But again, the PBMs are pushing out away from some of the community pharmacies and push people to the retail pharmacies.
That's a shame, because that's where it seems like, from what you're saying, that advocacy can happen.
More advocacy can happen at a community pharmacy, definitely.
Okay.
Or find you a good technician or pharmacist at a retail, larger, maybe corporate retail, that will take the time when they have it. Again, that's the best part of the day, is to help someone.
I bet, yeah.
But to find that time when, like if you're on the highway, you just can't stop on the highway, right?
No,
So when we are running through our day in the corporate world, we got to take the exit, go help the patient. That's the best part of the day, is to help somebody understand a question or help them get what they need, whether it's OTC product or getting help understanding something.
OTC meaning?
Over the counter.
Over the counter.
So when they come ask a question about, hey, what can I get for my cough? I got this itch, I got whatever's going on.
Okay.
Can you help me find this or recommend something? A lot of the PBMs, pharmacy benefit managements or managers, want to push people toward mail order too now, which your medicine comes in a box and there's no, like, what do I do with it now? Because you try to call them. There's no person. No person there to spot. You can route and try to speak with a pharmacist, but you're over the phone. You lose all that personal connection.
Yeah.
So I say and
that's kind of scary because it's the pharmacist that can catch a red flag, right? And say, oh, wait, this was increased or this could happen here.
We are there. Most pharmacists are there. They can speak with the patient. They can call the patient. And again, I see a danger in most of these red flags. We make a note of it. We're going to speak to them, but they're in a rush. They're out there picking it up. Like, do we have time to sit down and talk to them right there when they're in a rush to pick it up or go on with their day? Especially if the place has a drive-through. You're sitting in the car. How do you have a proper discussion about the medication? Now, luckily, a lot of people do come in for those conversations, which is helpful.
Yeah.
We should always take time to take that conversation, discuss medicines with them.
Right.
Or, perfect world, we take time to call the doctors and tell them what worries we have. Now, again, doctors, they don't want to be second guessed. But when you have an honest conversation with the doctor, we're concerned about, you're giving them this, they already have this, or you're giving them these two, were you aware? Because the doctors have like 1 semester of medication training. Doctors I've talked to, they get 1-2 semesters of medicine, discussing medicines in their classes. We go for 3 or 4 years. That's our doctorate is understanding how the medicine works, how they interact with each other. Right. Like 2 or 3. We spend 2 or 3 semesters on how they interact with each other. Right. So very few of the patients know that we are that aware of what. Well, my doctor wrote it for me. He must want me to take it. It must be safe. No, not necessarily, depending on what else you're taking, or your age, or your medical conditions. So
when I would help, if I were to help somebody navigate, and they had questions about their medications, it would be talk to your pharmacist, so they can see if there's any conflicts or anything like that. And if you're having symptoms of something, of course, talk to your doctor. And but to understand that you have resources between your pharmacist or your medical doctor.
Usually they can find someone at the pharmacy that can take time to help answer a question or to find help. Because when people come to the pharmacy today, I would say a good 50%, there is currently some issue with insurance. They're not understanding how their insurance is working, why their insurance won't pay for it, why their insurance is wanting to change their medicines. So that's an ongoing battle every day. So I think one of the questions you want to ask was like, when somebody comes into the pharmacy, what should they be understanding what's going on in the background? So when we're in the pharmacy, we're getting new prescriptions in, we're preparing new prescriptions, but we're also dealing with insurance issues, dealing with a lot of these, we're getting messages, red flags about what they're taking and what the doctor's trying to give them.
Right.
So we're trying to address those issues, either calling patients, calling doctors, doing those things in the background.
That people can't see or that wouldn't know. So you mentioned that sometimes, I guess with health insurance, there's an alert with medications that maybe this medication has been picked up somewhere else, right? But what about when they're using they're using cash, or they're paying by cash, or they're using savings, or they're using GoodRx? Is there potential for duplication in those? Definitely so.
So that would be a way. It could be duplicating, like if they're using GoodRx for something and they're getting different blood pressure medicines. It's a risk that the insurance is not aware of that. So that it's not going to trigger, hey, this is too soon, or we have a therapy duplicate. Insurances will let us know there's a therapeutic duplicate sometimes. And it will tell us they're getting filled at somewhere else, possibly a similar drug. and we could look into that. One thing I would say people need to understand is when your doctor writes the drug, let's say Jardiance versus Farxiga, they're two diabetic medicines.
Okay.
They're sister drugs. They're in the same family, they do basically the same drug.
Okay.
The insurance, PBM, may prefer one or the other because they get money back from the manufacturer to say, hey, let's try to get your patients or your members.
So is it about the person or is it about the money that they get back? Or does it matter because they're sister drugs? I mean, how do you, am I starting to get a little bit, I guess, upset over this? Is it about the person or is it about a kickback?
For the insurance, it's about kickback.
Kickbacks, okay.
So, I mean, there was a major insurance company this week, and I sent the information about they were getting in trouble with the government and Medicare or Medicaid because they were charging or not doing, they were, I wouldn't say cooking the books, but they were getting more kickbacks from the manufacturers than they were reporting to the government, basically.
Okay. Okay, and then we're all in the middle of this trying to get well.
So let's say Jardiance, just for example, Jardiance, whoever makes it, I'm not even sure. I can't remember who makes it, but they will probably either give the insurance or give the customer a rebate to use their drug. So you got your insurance will pay for it. Sometimes they'll give the rebate directly to the insurance. Hey, take this amount off of their copay and give it to the customer at this price.
Okay.
Versus them having to deal with, go to the Jardiance manufacturer, ask them for a coupon, like a GoodRx, but specifically just for Jardiance, and help them reduce your costs. Okay, so a lot of times during the day, people come to us like, my insurance wants, why is my medicine such and such? Well, that's the cost from your insurance. You may have a deductible. That may just be the tier copay they want you to do. So again, and another thing we can discuss is choosing plans. But a lot of people, we do refer them, go to the website of the manufacturer, see if there's a coupon available, which a lot more of them, fortunately, now are available to help with Medicare Part D plans.
Okay.
A lot of times before, like if they had Medicare, Medicaid, any type of government plan, especially including Part D, which is the biggest one, would be they can't use this coupon card, but they're the ones majorly using the medicine. So a lot of times now the government, the Part D, is allowing those to be used together with coupon cards from the manufacturer.
Okay.
But that is a big thing is the insurances a lot of times are choosing what medicines the patients are on versus the doctors. Or the insurances or the drug companies, the manufacturers are trying to influence the doctors on which medicine to put their patients on.
Wow.
Not direct kickbacks, but
I understand.
benefits of some sort.
Benefits of some sort.
Yeah.
So it's the patient is kind of prioritized last in
Sometimes.
some ways, not all the time,
right.
but sometimes. Interesting. What has surprised you since you've been a pharmacist? What would you say the number one thing that has surprised you the most?
Just the daily grind that we don't really have time to help the customer, help the patient. There's it's the push to do everything else versus who's there in front of you, which is the customer.
Right. So like the healthcare system that's very task-oriented.
Right.
Task. And the customer or the patient or the client kind of sometimes is prioritized last because of all the tasks that are in front of a person. So that has to be kind of disheartening at times.
Yeah. I try to tell the technicians, I mean, it doesn't matter what's in front of you, go help the customer. Go help them, see what they need. Versus trying to get something ready, they can't get to it if you get it ready, what's the point if they can't get to it? If they can't get to you, if they're having to wait 4 or 5 people in line or 15 minutes in the drive-thru and they get discouraged, what's the point of you getting it ready for them?
Right. What keeps you passionate about doing what you do as a pharmacist?
Just the changes over time, because there's always promises, okay, we're going to be more patient-oriented.
Okay.
Take time to help the patient. You know, help the patient in their healthcare journey.
Okay.
So taking time to do that would be the biggest passion and the biggest effort I think pharmacy needs to make. And like you said, the mail order. A lot of the pharmacy is trying to push people out and just send them their medicine and try to get rid of this interaction between the customer and the pharmacy.
That just seems dangerous to me.
Yeah.
It just does.
So yeah, it's all the pharmacy world is understaffed. Like you asked about other types of, like when there's the hospital pharmacy. It's similar to the community pharmacy. They outpatient. Sometimes they'll get the medicine that they're given in the hospital and send them home with it.
Okay.
Because rarely do they, unless it's an emergency room, they'll send it to the pharmacy. But a lot of times if they're in the hospital for an extended time, surgery or extended illness, a lot of times they'll get their medicine ready that they're taking in the hospital and send it home.
Okay.
Get it ready and send it home with them. And a lot of times when you're in the hospital pharmacy is a little bit different. They definitely have time. They will oftentimes take and sit down with the patient about what they're getting and getting sent home with, which is good.
What should, I know people must get very upset when they're in the pharmacy because they don't have access to their doctors in that moment. Things don't go the way they want them to go. And they don't understand the process because unfortunately, there's a process. What are the best questions that they can ask when they're in the pharmacy for themselves? And what are the questions after that? What are the questions they can ask their doctors before they get to the pharmacy?
I would definitely, if the patients at the doctors, I don't want to speak for all doctors. I'm assuming this is all assumption that the doctors say, okay, I'm going to give you this, and this medicine, and we're going to change this medicine. Before they left, if the doctor won't explain it to them, speak with a nurse before they change. What medicines are they giving me? What's changing and maybe why?
Right.
Okay, we definitely can help them with the why, why they may be changing or what the doctor's thinking.
Right.
Because I would say daily, a lot of people have assumptions about what they're taking and why.
Okay.
And sometimes, like you said, the biggest, like the questions that come to us and the people are taking their medicine wrong or they're having incorrect thoughts about why they're taking the medicine or they're not aware of what side effects can combine. A lot of things is not about the side effects of one drug, but it's the side effects, like you said, of all the medicine they're taking together.
Okay.
Okay. Or I would say an advocate is needed to help people understand that they have to take their medicine consistently.
Okay.
Okay, because
they can't pick and choose.
Can't pick and choose. A lot of people do pick and choose, which is, we hear that, I wouldn't say it's the majority of the time. We do see occasional. That's a good, because most pharmacies have a system where they're calling their patients partly because their system will notice that maybe they're late picking up their medicine or they're not consistently picking up their medicine, which means they're probably not taking it consistently. Or the insurance will sometimes more now. Well, the insurance, like you said, if the insurance, and this goes back to the GoodRx, if the insurance notices that they haven't paid a claim for it in a while, they'll call and ask, has this person gotten this medicine?
Okay.
And it could be, yes, they paid out of pocket for it.
Okay.
Okay. Or they want to know if they picked it up. So that's one way we could kind of see, because that's a deeper concern. Like, are people taking their medicine properly? That's another. They get their medicine, but are they picking it up? Are they taking it properly? Mm-hmm. That's the next step of helping them get the medicine. Is kind of our world.
Right.
But then helping them take it correctly is another part.
Right. If they don't know what it's for, they may have a hard time taking it correctly.
Right.
So.
Or they're not quite sure what it's for,
Mm-hmm. What advice would you give to someone that had a hard time speaking up for themselves to ask either the doctor or the pharmacist questions? What kind of advice would you give that person?
There's somebody there that will speak with them. To find somebody there, either a nurse, technician. I think a lot of times unfortunately, we've gotten too quick in the world, too big of a hurry. Either you can leave a message, say, can the pharmacist call me when they get a chance? And most I hope all pharmacists would do that. Like if you're in the rush at the moment, take the time, say, I will call you back, or set up a time for them to come and just dedicate that time.
Right.
When you know you have other extra pharmacists that can handle immediate concerns.
Right.
Or the nurse at the doctor. I would tell the patient, somebody at the doctor's office can take time for you, either to help you. Like a lot of times I'll refer when we have problems with the insurance, or people, again, I'm outside of the medical doctor world. So I see a lot of people going a long time between their doctor visits. The doctors will notate on some of our electronic prescriptions when they were last seen. It's been months, and they're just keeping them on the same medicines. Or we'll get notes on our prescriptions, patient needs to make an appointment, and they'll still give them 6 months of medicine.
Even after you see patient needs to make an appointment, and they'll
give them still 6 months of refills, and they're not seeing the patient. So I would say, I know you see more of the medical side. The doctors are crunched on time too. But I would say
they are. Yeah, same.
So I'm assuming people just are hesitant to go to the doctor, and especially spend time enough to understand what they're taking and why on their medical concerns.
What I hear is the same thing I hear from you as a pharmacist is really the same thing I hear from a doctor. They want more time because they went to medical school because it was about the patient, not about insurance and all this process that there's a million executives and fewer doctors today. So I hear the same thing, not with the executive part, but saying, I want more time with the patient. So if you had your pharmacist,
that's my number one thing I would want is more time to take and spend with the patient, or assessing what they're taking, so I can have a proper conversation with them or the doctor.
Can you imagine, though? Could you imagine, Chris, having an office, like your own little office? This would be amazing. And then people would have to come and talk to you and sit with you. And then you could say, okay, I'm going to look at, because I've seen a medication reconciliation that was done, and it was scary because all these medications were removed after the doctor said, oh my gosh. Oh, yeah. But that would be amazing. What an amazing thing to be able to have that time and say, okay, well, let me explain it to you. This is how you need to take it. This is why you're taking it.
We hear horror stories. We have people, wonderful people will come. They'll bring their lunchbox full of medicine and just dump it out, and they have no need. They kind of cherry pick what they're taking sometimes, or they're not sure what they have or why they still have it or what they're supposed to be taking. And with all the names of drugs, they're confused on these two are the same. They're sister drugs. They're doing the same, supposed to be doing the same thing, but you're still taking both. And it could be from two different doctors. Well, my hospital, I left this with the hospital. My primary doctor had this. Yeah.
They go home and they still have something that they're supposed to throw away or get rid of.
We see somebody, we get the discharge from the hospital, and it says follow up with primary. We don't have time to say, hey, Miss Smith, did you go follow up with your doctor about here's what the hospitalist gave you, here's what you were taking. We need to reconcile these two things that what the hospital doctor or maybe a cardiologist told you to take versus what your primary doctor had you on because something happened. You had a heart attack. You had a stroke, you had a diabetic situation, crisis.
Yeah. And what's happening too, I noticed, is the coordinating of care is not being done. So when someone leaves the hospital, if they're not feeling well, they're supposed to follow up with their cardiologist or their primary care doctor. It's not being done for them, even though they're very sick, or possibly the caregiver doesn't understand how to do it, or the discharge was done very quickly. Those things happen and they fall through the cracks.
Right. So I would say definitely the best plan of action is keep a list of your medicine at all times. Because if you go to the hospital, take that list with you. A lot of people I know, we recommend put a list on your refrigerator, what you're taking. regularly take that to the pharmacist, say, here's what I'm taking. Can you review this in your time and call me back, or contact my doctor if you see any concerns?
Okay, that's good. That's really good.
And like I think I told you, Charlotte's a bigger town. I was growing up in a small town and worked in a small pharmacy there while I was going to school. And we regularly knew the doctors. We could call the doctor, talk to the nurse, knew them personally most times. In the smaller towns, you could have that conversation with them.
That's nice.
We're in a grind here, crunch here.
Yeah.
With
they just don't have the time.
Right, or you have a big medical group and you could see multiple doctors, and confusion does occur. Perfect world, everything happens. We have to see a list, we can know what they're taking. As far as going back to the PBMs, probably as an advocate, they recently, most of the big insurances now have this week and very recently said they're going to, the biggest people come to us, okay, I would get there and say a percentage. Okay, your drug needs a prior approval. We get messages all the time. I'm saying 30.
So
I would
who's
say
saying
20
prior
times an hour.
approval?
We're getting a message.
The insurance company is saying prior approval?
Insurance is saying that prior approval is needed for us to pay for this medicine. Mm-hmm. Right now, that can take, depending on the insurance, Medicaid's a little bit quicker. If the doctor gets on it pretty quick. Medicaid's pretty quick, probably a day, 2 day turnaround, 48 hours. Some of the big insurances, we see prior approval sit out there indefinitely.
Really?
Depends, and part of it's communication. So definitely, if as an advocate, find somebody if you're not getting answers on your medicine and what they want to do with it, whether it's change it to something else or get it approved, once the pharmacy tells you, hey, we need a prior approval, I would say get your advocate or personally call the doctor.
The doctor's office. The doctor's
You're not
office.
getting anything from the insurance.
Okay.
Insurance is going to be, insurance is all outsourced.
Okay.
All customer service of the insurance is outsourced.
Okay.
And you were talking about AI. Part of it's AI. So when you go to the doctor, you may get a bill, or the hospital, you may get a specialist, whatever, you may get a bill 2 or 3 weeks later. Here's the services we perform. They take an estimated copay or whatever.
Okay.
They may send you a bill 2 or 3 later. This is what wasn't covered by your insurance as when we submitted it, and here's what you owe us the difference.
Okay.
They take care of you, and then they send you a bill later. Is that right? I would say. Sometimes.
Yeah, they take care. Sometimes
they estimate.
I've seen it right away.
I say they'll estimate. They'll estimate. This is what we estimate the charges to be. This is what we estimate insurance is going to pay for.
Yeah.
And it may be, it's probably pretty close most times.
Yeah.
Then they may send you a bill later and say, well, actually, this is what you owe.
Yeah.
When the insurance has got back to them, because you get your EOBs, your explanation of benefits from your insurance.
Yeah.
We don't do that in pharmacy. Pharmacy's like, hey, here's the price they owe, or no, we're not going to pay for this right now.
So they call their doctor.
Speak with the nurse. Probably most doctors now will have some type of person that's dealing with all billing or insurance issues.
Okay, yeah, they have a billing department.
One person at the doctor is probably, all they're doing all day is prior approvals.
Okay.
Either on their end, medically, for procedures, tests, whatever, or from the pharmacy sending them messages, hey, this drug needs to be approved for X patient.
Is that, okay, so it needs to be approved because it's not on their formulary.
Or because of cost.
Because of cost.
Okay. Like if the drug, like just for example, Mounjaro and Wegovy, everybody's talking about Mounjaro, Wegovy, Zepbound now. Okay. They cost $1,200 to $1,800 per month.
Okay.
So that cost, that's what, and we've heard news about the United States is being charged that price, where other countries is probably half of that, or even not even that. It's not.
Right.
They're not. The cost of the drug is escalated here for some reason. They're looking into that because of the cost of that. They just say prior approval, or they don't prefer that drug. A lot of the pharmacy benefit managers are choosing. They're choosing side. Hey, we want to go with this drug, so we want all our patients to be on this drug if they're going to be on that class of medication.
Okay.
So that is mostly AI generated. Like there's not a person, we send it, the computer says, their computer system is saying, no, we're not going to pay for this, you must get a prior approval. Or their computer system is generating a price to send back to us to charge the patient for a copay.
So if it's AI generated, in which AI is, in some cases
Or
has evolved,
computer
system,
softwares.
Are there errors that are coming about because you're not talking to a person, so you're not understanding?
Yeah, you're in there trying to manipulate their computer system as far as getting to talk to someone or to put in that this is approved, this should be approved and proper code. So there's a lot of going into that, or it takes time for the insurance to put in that it's approved and what their copay is going to be. Or the insurance will tell them a certain price and it comes back different.
Okay.
That was more transparent in the past. In the past, we would get information back at the pharmacy level as this is what their deductible is, this is what their out-of-pocket cost is, here's the drug price, here's what we're going to give the pharmacy, pay the pharmacy to give it to them.
Imagine that, transparency.
Yeah, so that's so we have less answers for the customer or the patient now. Also, this week, most of their insurances, because of government pressure, have said we're going to shorten that time frame for prior approvals. We're going to try to expedite that.
That's good.
To make it quicker.
Okay.
That we can get some answers. And also, they were going to allow, let's say, you're at the end of the year. Mm-hmm. We'll go with probably the people we need to help the most is people on the Medicare Part D.
Okay.
Our elderly population, we're growing older daily, to help them stay on the medicine they're on. So you get to the end of the year, most Medicare Part D plans are going to change at the end of the year.
Okay.
Either you change, or if you keep the same, they're supposed to tell you what their formulary is. Okay. I would say don't trust that always. If, like you said, somebody calls you, hey, I'm from Humana, I'm from Aetna, Humana, whoever, I want to sign you up for your plan again. I would get them to send in writing what their formulary is before you sign up for it. Just don't take token word. Hey, your plan's going to stay the same. Will you stay on the same plan? You want to go to this plan?
Right. Yeah.
Because we do change medicines, but I would always know what medicine you're on so you can look at their price plan. They have to tell you, per Medicare guidelines, what this tier is going to be next year, what this copay should be. And there's a lot of confusion this year with Medicare D as far as when the price comes back. Is that deductible? Is that donut hole that they're pushing to the front of the year? I see a lot of insurances, it's my assumption, a lot of these insurances were like you have your plan, you have your whatever you pay in, your premiums, and they're supposed to give you a copay estimate. And everybody's supposed to pay a deductible. I mean, some plans have zero deductible, but most people, they need that because they have low income and they sign up for those plans or they're eligible for those plans. But the majority of people, you have your deductible you have to pay. Okay. And then you should have your normal copays after that. For medicine medicine you knew you were going to be on, should stay the same price based upon what they quoted you when you signed up for the plan. And then you hit your donut hole, which you have like $2,000, $2,500, depending on your plan, that once you've paid, the insurance plan has paid so much in, you have to pay a larger amount. And then once you hit your end of the year catastrophic, where you pay basically zero for your medicine, once you've paid into what we used to call the donut hole. But last year, something went really haywire, changed a lot because they've pushed all what you owe to the front of the year.
There were a lot of changes last year.
There were a lot of changes. They ended up pushing all that money you owe to the first of the year. They said, well, we're going to get all the money we can out of you before we bring these prices down. But it's kind of like you go to buy a TV and they quote you, the TV is $300. If you do a rebate and if you have such a plan. If you have like a plan with the membership, you have a membership plan, and you get your rebate. You can have this TV for $300. You get to register, and it costs you $1,000. Why does this cost $1,000? Well, you didn't. Have you asked us for a rebate? Have you signed up for a plan? You can, or some people are used to being, okay, you go to the pharmacy, you kind of expect, you pay your deductible, and once you've paid so much in, it's going to go back normal. But then or it's been like, they don't apply the full deductible. It's kind of a tapered deductible. You pay a little bit. But people have been hit with these big prices for medicines they made, like Eliquis, like blood thinners, not warfarin, but Eliquis, diabetes medicines, the Farxigas, any of the name brand medicines have been hit with these big prices because the insurances are pushing all of that deductible, all of that donut hole first of the year.
Wow.
And people, if they call, can get that price brought down. So do get somebody who can call Medicare, your plan, and they will bring that down.
They will. Okay.
And spread it out.
Do you think so? It would behoove somebody to have a good agent to help them, not just try to do it on their own.
Right.
Because it sounds like there's just
have
so many
someone,
factors
if not
that
at
you
the
can
pharmacy
trust.
or the doctor, that they can trust to kind of look at their medicine and take it to somebody to help them, especially if they're not able to manipulate the computer or the phone and look at their plan, or look on their computer and see what their plan should be paying. Medicare.gov is a good resource, I would say.
Okay.
Because they should, when you go into Medicare.gov, that would be the place you actually sign up for a Part D plan.
Okay.
All the plans that are eligible for your area should be listed. You should be able to make a comparison. Well, I know a couple, for a little while, some of the corporate pharmacies would allow us to help people look at those.
Okay.
And it was helpful, people to see that, like put in your list of medicines. People can do this at home. You can put in your list of medicines, and they're supposed to give you an honest price on what your plan would cost.
Okay.
And how much it should cost you, or how much your deductible is, or what make a choice as a plan. A lot of people, like when they choose their insurance, kind of the same thing, but the Medicare plans works kind of the same way.
Yeah.
When you choose and compare plans. But with the kind of pressure from the government, hopefully most of the insurances are going to allow people to stay. If they get a prior approval within one insurance and they happen to change, they're supposed to allow them for up to 90 days to keep that prior approval in place.
Okay.
So they don't have to change medicines.
Okay, that's good. And I guess in a perfect world, I was just thinking when I was talking about you being in an office and people coming to you, you being also that guide as well.
Right.
Because I find people end up with bad agents.
We would be the best agent to do that.
Yeah, because you
if we were allowed to do it, if we had
were,
the time. Look, again, time is our biggest drawback in the pharmacy is having time. Because if we pay that price of time, if we pay the price to take time to help someone, then something else is on fire behind us. Just want people to understand that most pharmacists, technicians, our teams love to help people.
I'm sure.
Take time to help people.
I hear that.
But understand, it may not be at that exact moment when you need help, but it should be shortly.
And the system isn't really conducive.
Right, it's not conducive at any particular moment. Because I know most pharmacies now are not taking phone calls. They're like getting a triage of phone calls to call people back when we can take a moment to try to resolve their question.
Right.
Which is good and bad. I mean, sometimes you need an immediate answer, like you're having a poison emergency. A lot of people would call the pharmacy if they had, hey, I'm having a reaction, what do I need to do?
Yeah.
And if that goes to a ringing line or a voicemail, then that's not the best option sometimes.
This could almost be 2 podcasts talking to you because there's a lot. Because I do want to talk about the robots, but we're gonna have to skip that because I wanna move on with life outside of the white coat, and that is it certainly can be stressful working in a pharmacy. I hear it. What helps you stay grounded, or how do you recharge when something's like very heavy like that? Because you're dealing with people. What do you do outside of work?
At work, I would just take a time. Always take a time to take a breath. It is a grind all the time. Definitely, I like sports. So I watch sports a lot. We have 2 dogs, and we walk the dogs a lot. Being out in nature helps. Take trips. We're going on trips we're building a house down in Lancaster County soon. So we're starting that soon. Hopefully got some house plans today printed up. So doing that, that's part of the looking forward to that and taking time to find stuff for the new house.
That's good.
As far as
that takes you away
takes you away.
You've got something else.
Yeah.
All right. So the next part is called fast and fun round. Okay. So this is pretty fast, but whatever comes to your mind first. Coffee or tea?
Probably coffee right now.
All right. Early bird or night owl?
Both, depending on the work schedule.
Okay. Dream vacation, mountains or the beach?
Oh, well, we haven't been to the mountains in a while, so definitely looking. I think we're going to go to the mountains for our anniversary next month.
Okay.
Yeah.
And how many years have you been married?
4 years now. 4 years.
Congratulations. Congratulations. Favorite, do you prefer a TV show or do you prefer a movie?
Probably more watching TV shows.
Okay. All right. Comfort food after a tough day?
Nothing particular.
Nothing particular. Okay.
Yeah. Just to probably try not, I would say the one thing, definitely tell people not to eat too late. As a pharmacist's advice, don't eat and then try to go to bed.
Spoken like a pharmacist.
Yeah.
And a hobby or a skill you wish you could master instantly?
Oh, golf. I've like a lot, we've, in a community where we're going to build, a lot of people are golfing. So I haven't really never played golf. Me and my wife have been talking about being able to just play a little bit of golf so we can take place in events with the community.
What's something that people would be surprised to learn about you?
A lot of people were surprised, that I was teaching, and I coached sports when I was teaching. So that background, a lot of people surprises them when they realized that that's what I did before I went to pharmacy.
What a great background, though, for pharmacy.
It's definitely helpful as far as managing the team, helping people with education, knowing an education background, how to educate people.
About medications and conflicts and what they're taking, that education piece. But I really do want to thank you very much in sharing your story with us. You've helped pull back the curtain on the pharmacy world and reminded us how important it is to ask questions, understand our medications, and never feel ashamed for wanting clarity. To everyone listening, your voice matters. Keep advocating, keep learning, and always know that you deserve to be informed in your own care and informed in your loved one's care. And we'll see you next time on My Patient Advocate. Thank you, thank you, thank you.